Kia ora koutou. Welcome to this online education workshop. Today's topic is around bone health with Community Gill as the presenter. I am Kasha. I'm with Midland Community Pharmacy Group in the Waikato, and I'm here just to MC today, and I would love us to start with the karakia. So the karakia from ACC to start us off today. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mō te oranga tangata, kia puta ki te whai au, ki te ao marama, humie, huie, taikie. Welcome, everybody. Christine, if you have that awesome power and control for the slides, if you would love to pop on to the next slide for everybody, that would be wonderful. Thank you.
Kasha, I'm actually frozen. Oh, there we go.
Oh, there you go.
Okay, back now.
So this is a good point to welcome everyone to a collaborative effort. This is a partnership between ACC and Sport Taranaki. Two people in particular that you can't see at the moment in the background is Campbell from ACC and Hilary from Sport Taranaki. So they have brought this webinar series together. They've done lots of amazing work in the background. And this webinar series is particularly for strength and balance class leaders. So welcome to all of you from throughout Aotearoa. Neat to have you here. As we go along through the presentation today, if you've got any questions, if you could just pop them in the chat, and be really neat if we can just save them till the end, and we'll go through them at the end. And then you'll also have the opportunity to ask questions with the mic off as well. Also letting you know that the recording will be available on the YouTube channel, and that will be sent out to everyone who's registered for today. I think that is a good background for the admin for today. So if we pop to the next slide, I can introduce you to today's presenter. Christine Gill is the Executive Director with Osteoporosis New Zealand. Kia ora, Christine. Neat to have you here. Thank you very much. Prior to joining Osteoporosis New Zealand, Christine worked for some years with the Connective Tissue Research Group at the Department of Surgery at Auckland University School of Medicine in the areas of infant nutrition, pharmaceutical and sports nutrition sectors. She has a BSc in biochemistry from Massey University. And when not at work, apparently you're rather sporty, Christine. You're an avid sports fan and enjoys mountain biking, water skiing and gym training. Neat to hear all of that about you. Now, I've also got another page of great details about Christine, but I'm just going to hand it over to you to get on with the presentation. Thank you so much. Enjoy, everybody, and remember, just make comments in the chat as you need. Thank you.
What I tend to do with this group in particular is just give you a bit of insight before I actually start into the bone health talk, just for a couple of minutes on actually where everyone fits in this amazing program that Osteoporosis New Zealand is working in conjunction with ACC on, and kind of how it fits into the patient profile in terms of the landscape that we're operating in, unfortunately, with bones, is one where consumer awareness is extremely low. We've obviously got a massive aging population, and the health system is also under huge pressure, as you're all aware. And particularly in the ACC context, this is resulting in a lot more claims as we're going forward. So our aim and our partnership that we're actually working towards centres around a document that was published in 2012 called Bone Care 2020. And what this did is actually set the whole landscape in this particular area of health for the next 10 years. And we're actually currently in the process of writing Bone Care 2030 that will be launched next year. And really what it does is sets up a systematic approach for the country on how we're going to tackle this massive problem. And just giving context, our whole aim and your aim really is to stop people having the worst fracture that you can actually have, which is a hip fracture. The reason for that obviously is that of the people who fracture their hip, there's about 3,397, so we say 3,500. And of those, unfortunately, 25% will actually suffer a premature death in the next year. So what we've done is put a whole range of programs, clinical guidance, standards, all sorts of things in place so that when people present to a hospital with a hip fracture, they get things like their surgery on time, pain management, all of those sort of things, and the rehab element, so that they have the best outcome for the patient. We've then gone on, and there's a massive piece of work we've done in the last 18 months to deliver best practice fragility fracture care and prevention in New Zealand, which is this whole space here. 50% of people who break their hip actually tell us they're coming because they break something in advance of breaking their hip, and that is usually their shoulder, their wrist, a vertebrae, or their other hip. And so what fracture liaison services do, and you will all have one in your communities depending on which region you're actually from, you will have now, we've just got full universal coverage, bar the wire wrapper who are gradually coming on board, where a fracture liaison service picks up anyone over the age of 50 who's fractured something due to low trauma. So we're not talking about people who have been skiing or fallen off their mountain bike. These are people who have tripped over the cat or fallen over the rug, and the fracture really shouldn't have happened. So this is where we're working progressively down. And so one of those elements obviously in that program is strength and balance, because if people don't fall over, they're less likely to fracture. So this is where both the work you guys are doing and the work we're doing to make sure that people have got bone protection meds and all those sort of things really cross over. And I feel that other teams that I've presented to in your space have actually quite appreciated how we kind of all connect together. And this all came under play as obviously the Live Stronger for Longer program, which we're all part of, and the program that we've been working with directly with ACC, as I say, to deliver best practice fragility fracture care and prevention by implementing world-class fracture liaison services throughout the country. What we're working towards is those all getting gold accreditation through an international provider, in which we engaged all the teams, did workshops, did surveys to find out the teams. We've given them new clinical standards. Sorry, I'm rushing through these quite quickly because I want to get to the context. And we also have a fragility fracture registry, which is actually capturing all those patients and making sure that across the country we have equity of care. So it doesn't matter if you live in Whangarei or Invercargill, you're getting the same care right across the country. And all of those services also measure whether people are doing strength and balance, referring people to nimble, all those sort of elements as well. So they're all part and captured. And we also have a toolbox where all of the services have protocols and templates and all sorts of things. So if anyone has strength and balance elements that they'd like to incorporate into the service that goes out to patients in your region, information is actually one of our KPIs, that we're providing direct information so we can share those sort of elements as well. We have Denise mentoring the country to make sure that everyone's getting consistent, and we have Kim forming the Fracture Liaison Network of New Zealand, where she's running education sessions and things similar to this. Moving on through all of these, so let's get to the bone health section. The reason that we have Bone Health New Zealand, and we launched this just before the first COVID lockdown, is we were finding a lot of people weren't engaging with osteoporosis. It's traditionally a medically old, people think they don't need to think about it until they're in their 90s. But bone health is literally something that starts before you're actually conceived. So the best thing you can do for your bone health is actually pick your parents, which obviously you don't have the option of doing. But it really starts from when you're pregnant right through to when you die. And the thing with bone health is that it's never too early or late to think about it. You've got 206 bones in your body, and it's actually a dynamic tissue. People often think of it as some kind of reinforced structure that's going to be there forever, because obviously they dig you up later, your bones are the things that are left. but it's actually a dynamic tissue that is replacing itself all the time. And on average, the whole human skeleton replaces itself every 8 to 10 years, no matter if you're 2 or 92. You've got cells sitting within your body that actually are making your bone turn over. So if we look at what a healthy bone actually looks like, we've got basically a section of sort of strong bone, compact around the outside, and a spongy bone in the middle. And if you magnify this, this is actually what the spongy bone actually looks like. And this is what good strong bone looks like. You've actually got quite good structures here all the way through. Now, to achieve that, you've actually got 3 types of cells in your system. So these are called osteoblasts that sit actually within your bone, and they're like the signalers that go, okay, I've bashed this bone, there's a little tiny crack, come over here you lot and fix this piece of bone. And so along come what are called osteoclasts. So anyone that's old enough to remember Pac-Man, these are like the munchy ones that come round. Literally what they do is they come like an oyster, they come and they sit on your bone and they inject acid into your bone, and then 24 hours later they wander off and it's dug a little pit. And then the osteoblasts come along and they literally fill in the bone, and then this whole cycle, so the osteoclasts have come along, they've built the bone, this then calcifies, and this whole process takes about 3 months to happen. So sitting here right now on this makes you feel a bit itchy. You've got thousands of those osteoclasts sitting on your skeleton, eating little bits away so that it can be replaced and strengthened. So by the time you're my age, your skeleton actually looks a bit like a patchwork quilt, not something that was in its original form. You've got little patches all over the place. And this here is for someone like me who likes geeky things like this. This is the normal strong bone. This is what osteoporotic bone looks like. The magnification of these 2 images is the same. So you can imagine if your structure of your bone looks like this, it is much stronger than bone that looks like this. Because what's actually happening in this is that you're an osteoclast, and this is this little guy here. This is an amazing image because they've literally caught an osteoclast moving off after it's dug a pit in your skeleton. So it's quite an amazing image, but unfortunately they can actually get quite aggressive, and you can see here that an osteoclast has moved off, but we've got quite a decent crack. And down the bottom here we've actually got where there's no structure left. So this would be like trying to build a bridge when you've got no structure underneath it. You can't actually do it. You can see there the 3 key images. So how does this all happen? With your skeletal life, so we're looking at someone's skeleton over their life form, there's actually 2 key times that we really want to encourage people. The first is where you're achieving your genetic peak bone mass. So this is the maximum strength your skeleton is ever going to be. And that actually happens before the age of 30. So after 30, it's basically all downhill. So we've got to work out how we maintain it. So what we're trying to say here is that for kids, we want you to actually it's set by genetics. So you need to actually know what your family history is like. Have you got osteoporosis in your family? Start that intergenerational conversation. But also get off your devices, get out and do your exercise. Think about your nutritional intake. Yes, it's calcium, but it's also proteins. It's also really a balanced diet. And it's also here not being too skinny. The fad now is to look great in a pair of jeans and be, skinny in your little crop tops and things like that. But it actually has a negative effect on your bone mass and your fertility, particularly in that, we get a lot of girls who go amenorrheic that are actually in their coaches, in kind of elite sports or, doing gymnastics 13 times a week. And a lot of swimmers we find are in this state because they're not doing resistance exercise. Swimming is one of the things that's not working your bones against gravity. So we want to make sure that people achieve the genetic peak bone mass. Now, excuse the maths for a minute, but for every 10% of genetic peak bone mass here that is not achieved, osteoporosis will come about 13 years earlier. So instead of happening when you're in your 70s, you might have it when you're in your 60s or even earlier. So if, depending on how high this is the outcome that you'll have of when it actually happens. Now, the next point, which has relevance of what actually happens, is that turnover that I just talked about a moment ago is actually regulated by your sex hormones, which is why, number one, it's often thought of a woman's disease, because unfortunately for us at menopause, our sex hormones drop off significantly. And so those osteoclasts are not being regulated by your sex hormones as they were before. And so they get more aggressive. And that's how, if you have a poor skeleton, they have the ability to eat through, like the image I showed you earlier. Now, women lose between 15 and 25% of their skeletal mass in the 10 years after menopause. Okay, so this is the other key time we want to be thinking about women knowing what their genetic peak bone mass is, what their bone structure is, and particularly this is why fracture liaison services look at people over the age of 50, because they are the people at most risk because their hormones have dropped, and that's where if they have a fracture at that point, we intervene so that they then don't go on and break their hip. So we're trying to pick up the first fracture to prevent the second. And as we go down our pyramid that I showed you earlier, we will actually then move to picking up people who are at high risk who haven't actually fractured, so primary fracture prevention. Okay, all making sense so far? This is an image roughly, so what they've done is taken someone's spine and they've cut a section through it horizontally. So this is sort of the density of your bone in your 20s. When you get your 50s, you can see it's getting a bit more sparse. In your 70s and in your 80s, it's getting a lot more sparse as you're going through. So that's generally what will happen with age. So it's literally a pediatric condition with geriatric consequences. Okay, so what you're doing when you're young, your genetic, peak bone mass, all of those things set you up for what you can do. Now, it's not all over. There are many things that you can do to actually make sure that you don't go from this normal bone structure to something really weak in between. So the first thing, as I've spoken about, is that if you have a fracture and you're over 50, that we actually pick it up, because it's unfortunately a silent disease that for most people, until they actually fracture something, they have no idea. So that's an unfortunate side of it. But once you've had that fracture, and they are common, 1 in every 3 women and 1 in every 5 men will have an osteoporotic fracture after the age of 50. And once you've had one fracture, your chance of having another one doubles. Fractures actually cluster in time. And so that chance of having that next fracture is about 80% in the year following the first fracture, which is why for fracture liaison services, we want them to intervene as soon as they can. We want those people to be referred into strength and balance so that they actually improve their strength and hopefully do some resistance in there as well. And so not only do they not fall over, but hopefully we get a bit of the impact sort of training or working your bones against gravity so that we can actually improve the bone structure slightly. And as I said, unfortunately for a lot of those hip fracture patients, 50% who have actually had a previous fracture, but 50% will not return to full mobility after the hip fracture. 25% will enter long-term residential care and not return to their original place of residence. And unfortunately, 25% will suffer premature death, which is why our pyramid starts at that sort of level. We are improving as we're going through to make sure that the interventions are there and stop people having that hip fracture in the first place. With bone health, we have a lot of known risk factors due to 30-year epidemiological studies that have been done. So we know the risk factors that we can look at, which is great. Age is obviously one, so the impact as you age will become more apparent. BMI, as I talked about, so being too skinny is another massive risk factor for bone health. The fracture history, and that is your personal fracture history, so you've had a fracture before, get onto it, but it's also your family history of osteoporosis. So if your family have had a hip fracture, if your sisters had osteoporosis, you are at a much higher risk factor for having poor bone health yourself. Not always, but it's another indicator that we should be looking at you. Smoking actually affects that bone turnover that I talked about earlier, so stop smoking. Now, the other one is medications. So some medications that are actually given for other conditions actually have a negative impact on your bone health. One of those which we look at are glucocorticoids. So anyone that's using relatively high dose glucocorticoids used for things like rheumatoid arthritis at a higher dose for a long period, we want to be looking at those people because that has a negative effect. Similarly, drugs for breast cancer, prostate cancer, HIV, those sort of medications. And this is where we'll move to identifying those people in the future so that we can stop them to going on and having poor bone health. Menopause, particularly if it's early, so we're looking at talking to women at menopause to make them aware, doing an awareness approach there. Alcohol for two reasons. One is if you drink a lot, obviously you have a much higher falls risk and you're more likely to fall over. Secondly is that alcohol actually impairs that bone turnover that I talked about earlier. Having a history of falls, so if you're a frequent faller, again, we need to make sure that those people's bones are okay so that when they do fall over, they don't fracture something, but to make sure that they are going to strengthen balance or using nimble to actually overcome the falling aspect of that side of it. And then there's obviously medical conditions. Similarly, those people have medications, but the medical conditions are generally breast cancer and the things that have been treated, but it's also people who have had anorexia to reduce their BMI. It's people who have got COPD, some other medical conditions, and that history of eating disorders or current disorders. So particularly for this younger generation who all of a sudden go, I'm going to be a vegan this week, they don't tend to do it properly. And it doesn't mean you can't have good bone health as a vegan, but you need to balance out to make sure that you are getting enough proteins, minerals, vitamins, all those sort of things, and not just go, Mum, I'm just going to eat the lettuce, take the meat away, take the carbs away because I don't want to get fat. They actually still need to have that balanced diet. And so for a lot of the younger people, it is often more of a risk because they're not taking the time to do that. Sort of been through all of these, there's a whole lot of things obviously that you can do, as I've talked through what are the risk factors, what you can actually do about it. So building that stronger skeleton, maintaining that healthy weight, eating the balanced diet, avoiding smoking and too much alcohol, doing the regular weight bearing exercise, and I'll go into that a bit more, and obviously knowing your bones. So we have a tool that people can use freely. It's on our website, bones.org.nz, and that website also has a number of fact sheets in it. We've intentionally written it in very simple consumer speak, and all of those fact sheets can be downloaded, so you can hand them out at your classes, and this tool is actually embedded in there as well, so that people can go on free and do an analysis of their bones and take that actually to your GP if you feel like you've got a concern, because it's quite hard to walk in and go, I want to talk to you about my bones. In a 12-minute appointment, a GP won't always have time to do a risk analysis. Whereas if you take your personalised report that this produces, it will have asked you all the questions about, do you smoke, do you take glucocorticoids, what's your family history, all of those things that I've just gone through. You can print out your report and go, do I need to be worried? Okay. This is my one. Fortunately, I've got bones like cement, which is great. So it shows you your risk of hip fracture in the next 5 years or 10 years, and your risk of any fracture in the next 5 or 10 years. So the dial comes through, and then you get this report here about that this is what the GP or nurse practitioner can actually look at to know what you should do next. So what happens when you take that report in? Firstly, they will actually talk to you about those lifestyle factors. So for all your patients or your own yourself or your family, they will look at all those lifestyle factors I've talked about. They will then talk to you about your risk or fear of falling, because obviously a lot of people who have that fear of falling, particularly if they've broken their hip, they tend to go into that sort of spiral of isolation, less activity, and not then going out, which causes a whole raft of sometimes mental health issues and all those other elements that come into it. So they may do then a Frex tool, which is essentially the medical side of what Know Your Bones is, just to look at it again using their own medical calculator. And if that is something that they're concerned about, they may send you off for a DEXA scan. Hang on, let me just find it, which is one of these. So the DEXA scan is a low radiation X-ray. It literally goes up through your hip and looks at what your bone structure is underneath it. And generally they'll do your hip and your spine. The worst part of it really is taking your height and weight. It really does nothing else in terms you just lie down and that's all that happens. So that's me. With exercise, what we're wanting to do is weight-bearing exercise. So things that actually work your muscles against gravity. So ideally you are in the gym lifting weights, things like that, but also it's things like walking, gardening, anything that you're out actually impacting your bones against gravity. Things that it's not are swimming and cycling. So they're great for strength and balance and keeping your muscles stronger, but not for your bones as such. Does that make sense? And if you do have osteoporosis, what we're trying to prevent is things that cause a high kind of compression force on those, particularly your spine. So you don't want to be doing things like Russian twists or the medicine ball or forward flexion or any of those kind of things, because they are likely or can have an impact on actually causing particularly a vertebral fracture. Okay, so just to be aware of people who are actually doing your classes, particularly those that do look more frail. I know all your classes have been accredited, so you shouldn't be doing these sort of motions, but just to be conscious of that. The good thing also with this area of medicine is that we do have effective treatments. So if someone does require a therapeutic side of things, we can actually have bisphosphonates, which can either be given orally or as an infusion. And for people who have more severe bone loss, there are some other medications that work in different ways, but teriparatide and denosumab, which require special authority. But they're pretty, they are all bone-specific medications. So they're not, they literally go in and coat the surface of your bones, these bisphosphonates, and they stop the osteoclast, the kind of munchy ones, being so aggressive. So you can actually maintain the bone that you've actually got. And that's the key between peak bone mass and before you hit menopause, is actually maintaining the skeleton you've got. So we want people to look at all those lifestyle factors, doing some exercise, getting vitamin D, eating that balanced diet, particularly calcium and proteins. But if they do have poor bone, we do have effective treatments that come into play. So from our side of things, what we appreciate is obviously the opportunity to do a talk like this, really to raise awareness for both, all of yourselves and your families. But if you can help us actually share and start this conversation, we're sort of in the place breast cancer was 30 years ago, where no one really talked about it. And that's the same for bone health. People really don't talk about it. They don't think about their skeleton. So the more you can help us share all the information that we've provided, share the Bones website with your participants in your classes. If you've got gaps that you don't see there of questions that your clients are actually asking, then feel free to email us and we can actually, develop another resource. Exercise is currently a big gap that we're very aware of, and that's a massive module that we'll be going into next year to actually provide some more exercise resources specifically. Bones website, as I've mentioned. So yes, if you can help us start the conversation, that would be greatly appreciated. And we do have a whole lot of assets that you guys can use and share with your clients if you'd like to. Thanks, Kasha. I think I'll hand back to you.
Wonderful. Thank you so much, Christine. Wow, there's so much information there, and your images were fantastic. In particular, I think your languaging around the munchy ones was very useful. It gives a very particular image in your mind to get your head around what's going on in your bones. Really, really useful. And through our participant classes, I think a bit more awareness now of what some of those tools are available to send out, not just through our newsletters and our own Facebook pages, and just having handouts available for participants in classes too, and get the conversations going will be great. Now, I haven't seen yet anyone who's put any questions on the chat, so either raise your hand if you've got anyone, or pop a question in. Would be fantastic if there's any particular ones. Oh, there's one. Which type of vitamin D is best?
Okay, so the first thing with vitamin D is it's not a vitamin because it's actually produced in your skin. So ideally what you need is to have about 15 to 20 minutes, depending on the time of year, with literally your arms and face exposed. It's not getting on your bikini and, you know, laying out flat. But actually vitamin D is produced in your skin by sunlight actually hitting there. Now, in terms of people who actually are unable to go out, so the frail and elderly, we do advocate for vitamin D supplementation. It doesn't really matter which particular variety that you actually use. Most of the vitamin D supplements are good, and the same for people who are particularly dark skin or veiled, who are obviously not getting that sunlight exposure. So we do have quite a few, you know, cultural elements that come into that. People who potentially wear long sleeves all the time or long pants permanently, and they don't actually expose their skin to vitamin D. We would definitely look at those people as well, having a form of vitamin D supplement.
Thank you for that answer about vitamin D and sunshine. The next question I can see is about aqua, which I think you briefly mentioned, but it'd be good to talk about that a bit more then. Does aqua aerobics keep bones strong?
No, because it's not specifically bones. Again, good for your strength and your muscles, but it doesn't work your bones against gravity. So you've got to be thinking about things where you're actually impacting. Ideally, you jump for your bones or impact them a bit, and that actually causes. So with aqua aerobics, it's like swimming, where you're not actually getting that impact of the bones.
Nice, thanks for clarifying that. No more questions from the group. How about then from me, considering a difference perhaps between walking or something that has some more jumping or jogging, in terms of how people would know which of those would be appropriate for them, if the risk perhaps of the extra jumping and jarring and impact?
It's really the flexion forces. It's not, you know, someone with poor bone health can actually walk or those sort of things. It's like any exercise, really. You've got to find something you like. So I can't tell you to go to the gym if you hate it. You know, it's find something that you're actually comfortable doing, you know, even gardening, because you're actually up and down and walking around and all those sort of things. So it's finding something you like, but just being conscious that it is something where you're actually working either with weights or your muscles against gravity, rather than something that's low impact, as in flotation, really.
Yeah. And really good to mention about what will ring people's bell, that they'll maintain that exercise and keep doing it every day.
So one thing actually that I didn't mention earlier in terms of the vitamin D question is that we don't advocate for the calcium supplementation. So the calcium that we refer to should always be dietary. So we're looking at, you know, dairy sources in particular, or fortified almond, oat, soy milks, those kind of things. So a fortified product is okay because you're still ingesting it. But distinguished Professor Ian Reid did some work back in going to say 2016, he did a massive research study to look at the impact of calcium supplementation, and it showed that you were more likely to harden the plaques in your arteries, which might result in a heart attack or a stroke more than what it would ever do for your bones. And so we don't advocate for calcium supplementation as such, but dietary calcium. But we do advocate for vitamin D supplementation, just to differentiate those two.
Thank you. Nice. Okay, there's another question here about yoga with the chair. So just asking for a little bit of information about why those positions of flexion and rotation can cause osteoporosis to worsen.
They don't cause it to worsen. What they do is they might result in a fracture. So yeah, that's a good question to actually ask. It won't make your bone health any worse, definitely, but if you've got really bad bones and you go like that, then you might actually cause a fracture.
Yeah. So thinking back to that that slide you had about the exercises, one of the points was the speed, wasn't it?
Yeah, it's something. Hang on, I'll just share that one again.
Yeah, that'd be great. Thanks.
Just looking at this slide here, so it's really actions that place large compression forces on the spine and increase the risk of a fracture, essentially. So it's the motion rather than, and it's really something that's quite jolting. You know, like if you turn slowly, then it's fine. But we often find people will get a vertebral fracture if they've got poor bone health, picking up the grandkids or picking up the shopping bags and things like that all of a sudden, or rolling over in bed. You know, people with really poor bone health, that's sadly that's the level of impact they need to actually have a fracture. And so what we don't want to do is intentionally do, you know, all of a sudden you're standing up and you do some forward flexion motion like this one over here. Hang on, I've lost my little thing. And have a vertebral fracture, or doing a Russian twist, you know, with a medicine ball. That's, you imagine if you've got bones that are quite weak and porous, you're actually going to cause potentially a vertebral fracture doing that.
Jacinda, if you're still there, who asked that last question, do you have anything else to add, or does that clarify things for you?
No, that was fantastic. Thank you. Great clarification.
Nice one. Pause for the questions. No more questions.
If there's no more, I'd just say I'd encourage you all really just to go on the Bones website, because I know I've imparted quite a lot of information quite quickly, but all of these are covered in a single fact sheet. So how the human skeleton replicates is a single fact sheet. Same with nutrition, same with, you know, all of the elements. And if you join our newsletter, you'll actually get those coming to you once every 21 days if you're interested, if you want to just get them cumulatively rather than having to sit down and read the whole lot. But go on and just see what your own bone health's like doing the Know Your Bones tool.
Yeah, I think engaging ourselves to start with is a really good point, because then you're familiar with what it is that we're recommending our participants get into too. Wonderful. If there's no more questions by the log, it sounds like everyone has enjoyed the session as much as me. Thank you very much, Christine. I'll close in a moment with the karakia, just letting everyone know that there will be a survey coming out following all of these webinars, just getting any other feedback. Otherwise, you can use the ACC Prevent Falls email or contact your Liege agent as well if you've got any particular comments or anything that you'd like us to engage with. And thank you again on behalf of me for Campbell and Hilary in the background for all these amazing webinars you've organised, and thanks Christine for the awesome presentation today. Nice one. All right. So if you've got the slide there, if you can find it, Christine, for the ACC karakia while I read it through. So
sorry,
to close, that's all right.
I'm not on your thing. Hang on, let me.
In English, while we're getting that ready, the ACC's karakia, the karakia for closing, is about striving to do what is right, undertaking to act justly, being considerate to everyone that it may improve the lives of all. Whaia, whaia, whaia te tika, whaia te pono, whaia te aroha, mo te oranga tangata, kia puta ki te whai ao, ki te ao marama, humie, huie, taikie. Kia ora koutou. Thank you so much, everyone, for participating today. And you can watch this recording in the future. Please stay in touch. And thank you.